So for many people, intercarpal movement is a bigger nightmare than the foot, because it's contained in such a very small area. So let's start looking at some of the surface anatomy that will guide us onto these structures. So the first thing is, when I flex Art's wrist, you'll notice there are 3 creases that immediately become evident. Why didn't you stand over there?
Okay, sorry.
Yeah, right there would be better.
Thank you.
Matt can move around.
Sorry, Laurie. Thanks.
All right, so there's the 3 creases. The most proximal crease is the most proximal extent of the synovial sheaths that begin up here and then guide the tendons through the rough area of the carpal tunnel. That's their function. Overuse, of course, will cause thickening in these tendons and cause pressure on the median and ulnar nerves, possibly, as they go through this region. So if you have thickening in these, you will feel the thickening right the way up to this point, and you sometimes will see it. The middle crease is the crease of the wrist joint per se, which is the radius and ulnar surfaces. And this crease, rather W-shaped crease, the distal one, is the attachment of the flexor retinaculum. So, if you're looking for the lunate, it will be between the wrist crease and the crease of the proximal carpal bones, or the flexor retinaculum, so it'll be there. And right here, we'll notice if we follow that flexor carpi radialis tendon down, that bobble that we just felt corresponds to this line. So the flexor retinaculum begins by attaching to the scaphoid tubercle. On the opposite side of the wrist, we follow the flexor carpi ulnaris down, we'll find that the pisiform is on this line. So the pisiform is also a proximal attachment of the flexor carpi, of the flexor retinaculum. So far, so good? Can I write on your hand?
Yes.
Is it good? That's good. Is that on? Is it switched on?
It's on there.
Okay, so there's the scaphoid tubercle. There is the pisiform. Not a lot of room for all that stuff to get through. If I follow up towards the tip of the thumb from the scaphoid tubercle, I will hit a ridge right there. It looks like, by the time you put it in, looks a bit like an exclamation mark. Scaphoid tubercle, ridge on the trapezium. That's the other attachment, the distal attachment to the flexor retinaculum. Now if I come off the pisiform and I run parallel to the thumb, out here I hit a very, very prominent ridge. On Art it's about 1/2 inch long, and this is the ridge of the hamate. So if we attach these, there's the retinaculum. According to Gray's Anatomy, that's a postage stamp shaped structure, but that's the oddest postage stamp I've ever seen. Now, on top of this is the superficial palmar fascia. Okay? Which also attaches to these indirectly, but sandwiched in between the palmar fascia and the palmar aponeurosis is the ulnar nerve. And the ulnar nerve does not technically go through the carpal tunnel. It goes over it. Right, so it's entering here like this, and then it splits into two parts. And this is motor. All of the sensory branches come off up here, and then they travel superficially to the fingers and palm. The motor branches come in here, and then it splits. This part going more superficially to the hypothenar eminence has to pass through this structure called Guillon's tunnel. And a fall on this part of the hand can lead to paralysis of the hypothenar eminence. Remember, no damage to these nerves can give us numbness, not the motor nerves. Then this one carries on into what's called the deep ulnar nerve, the deep motor branch. That is going to supply this huge muscle called flexor pollicis. That's the one that's responsible for this movement. Interestingly, when you have a C8 palsy, it's like somebody scooped the palm out, right? Because it supplies C8. And also the interossei of the third and fourth interossei muscles. The median nerve travels into the carpal tunnel, which is between the actual carpal bones and the palmar fascia. And it will supply the 3.5 digits, as it's called, and including the fingertips. So in other words, right up to this point is median nerve. But before it goes into the tunnel, it gives off what's called the recurrent median nerve, or the recurrent palmar branch. And it comes off right here, just as before it goes in, goes over the scaphoid and then into the thenar mass and supplies this area of skin. A true carpal tunnel has this area of skin normal. If this area of skin is numb, then the compression of the median nerve is above the carpal tunnel, proximal to it. Little pieces of anatomy like that help incredibly in the diagnosis.
Because it's only motor that goes past that point. Is that what you're saying?
Yes.
Okay.
This branch is purely sensory. The motor branch continues in whole, as a whole, right through the carpal tunnel. And we'll see wasting of the thenar eminence and the proximal two interossei. Sorry, the radial two. Pisiform, scaphoid, trapezium, hamate. What do you think's in the middle? The capitate, right, the big C. Capitate means central, right? Capitus means central, so, and that's a perfect definition for this bone because it's right in the middle. Trying to find the capitate here. So from the palmar markings again, the bony ones you can feel, capitate you can't, but you know it's smack in the middle of these four bony points. The Body of the scaphoid is right here between these two creases, and the body of the lunate is over on the ulnar side between those two creases. A lot to find. And eventually you've got to find all of this without looking, because you will be assessing the hand like this. So can you find those bony points without seeing them? Because you don't need to see them because you're using your fingertips. Okay? Thank you. Make sure I return it. Okay? Let's enjoy finding as many things as we can on the palmar surface of the hand.